of fibrillary glomerulonephritis, which presented to our facility. She was a 67-year-old female who was sent in by her PCP for ongoing fatigue, difficult to control hypertension on a combination of diuretics, ACE inhibitors, and amlodipine, as well as abnormal creatinine. She did not have any symptomatic complaints other than her review of systems, which was positive for dry skin and hair, constipation, nausea, fogginess, and slow thinking. She has a past medical history of hypothyroidism, hypertension, hyperlipidemia, and mitral valve regurgitation. The remainder of her history, including her surgical history, social history, family history, and allergies, were unremarkable or non-contributory. Her medications are listed here. Her initial vitals are listed here as well. You can see she was hypertensive on admission. Physical exam, unremarkable for anything other than some slight peripheral edema. Initial labs you can see here, the most notable of which is the creatinine of 2.99, the hypercholesterolemia, and the positive anti-nuclear antibodies. She also had a urine protein electrophoresis, which showed an M spike as well, and a renal ultrasound showed structurally normal kidneys with slight reduction of corticomedullary differentiation. Nephrology was consulted and a renal biopsy was scheduled, which showed, as you can see in these images here, a crescentic diffuse segmental proliferative fibrillary glomerulonephritis with moderate interstitial fibrosis and moderate arteriosclerosis. In these images, the top two are our light microscopy images, which show the hypercellularity, the circumferential cellular crescents, and some of the deposits as previously mentioned. This second image in the middle is our direct immunofluorescence microscopy, which was stained with a antiserum specific for fibrinogen, which you can see there's also some hypercellularity where the arrow is pointing. And then this last image is our electron microscopy image, which shows a lot of those fibrillary deposits. You can see these thin lines here indicated by those measurements in nanometers. I apologize, it's a little bit small. So this patient eventually was started on cyclophosphamide and prednisone, but unfortunately her renal function continued to decline for approximately 2 months when she progressed to end-stage renal disease and required hemodialysis. Fibrillary glomerulonephritis is very uncommon. About 0.5 to 1.4% of biopsies result in this diagnosis, and it was once considered idiopathic, although there are some more recent associations with Hep C, monoclonal gammopathy, malignancy, and autoimmune disease. Typically, patients present like ours with a nephrotic type of picture, renal insufficiency, hypertension. On pathology, typical findings include fibril deposition in the mesangium and basement membrane. There is a specific protein called DNA JB9, which is a heat shock protein that is a large component in these deposits, typically complex with immunoglobulin, and some of the damage to the kidneys may be due to autoantibodies against this specific protein, which could eventually possibly be used as a diagnostic tool. Currently, there's no guidelines for this disease, and there's very limited data as it's such an uncommon diagnosis, but underlying causes should be excluded and treated, of course. Typically, treatment is approached by degree of renal dysfunction, so if the GFR is greater than 60, conservative measures are preferred, but as it continues to progress, or if there's crescentic disease, immunosuppressive therapy is recommended, including cyclophosphamide, Rituxan, and glucocorticoids. Eventually, patients typically progress to ESRD in about 24.4 months, with a degree of fibrosis and the initial creatinine being the prognostic indicators. Renal transplant is also an option, but there is the risk of recurrence, and unfortunately prognosis continues to be poor in these patients. So you can see in this patient there was a very fast progression in 2 months rather than 24.4 to end-stage renal disease requiring hemodialysis. So we recommend to maintain a high degree of suspicion so that treatment can be initiated promptly to delay or prevent the need for hemodialysis